And so I'd especially like to thank Dr. Emanuel for helping us keep ideas and community aloft here at Town Hall. Tonight's presentation will run around 30 minutes, followed by an audience Q&A. You can view the event on Crowdcast, Facebook, or YouTube. And to participate in the Q&A, the easiest way is to submit directly through the Ask a Question button on Crowdcast. Try to stay succinct so we can get to as many folks as possible. Also, for closed captioning, YouTube is your best bet. You can enable real-time captions using the CC button in the bottom right-hand corner. Town Hall adds new events and podcasts every day. Upcoming programs include Erica Barnett with Claire Dieterer about drinking, relapse, and recovery. Nicole Hannah-Jones of the 1619 Project with Brenton Mock on race, journalism, and justice. And Congresswoman Pramila Jayapal with Naomi Ishisaka offering a blueprint to action for the next generation of women and people of color in politics. Also, make sure you visit Town Hall's media library for hundreds of events from both the recent and pre-COVID past, which actually, as I say it, is also relatively recent, but that's not important right now. Town Hall's work is made possible through your support and the support of our sponsors. Our Civic series is supported by the Real Networks Foundation, the True Brown Foundation, KUOW, and the Wyncote Foundation Northwest. But fundamentally, Town Hall is a member-supported organization, and I want to thank all of our members watching tonight. On that note, Town Hall, like other nonprofits, has been hit hard by the economic impacts of the pandemic. Tonight's event is free to maximize access, but we hope you will consider a donation by clicking on the button at the bottom of Crowdcast or by using the URLs in the comment threads, panes, I should say, on the other platforms, or by becoming a member on our website. One last economic point of data, since you're likely to want to learn more about tonight's topic, and let's be honest, if we were gathered together tonight in our great hall, many of you would be visiting the book signing table. We will encourage you to use the link on this live stream page to purchase your copy of the book through our terrific partners at Third Place Books. Please consider buying the book, and just as important, when you do, buy it local. And just maybe some of the things that we loved about our community pre-epidemic might make it to the other side. All right. Though you likely think of him among the country's most admired and authoritative voices on health policy, Ezekiel Emanuel is at heart an oncologist, a bioethicist, and a teacher. He is the Vice Provost for Global Initiatives, the Diane V.S. Levy and Robert M. Levy University Professor, and the Chair of the Department of Medical Ethics and Health Policy, all at the University of Pennsylvania. He serves as a special advisor to the Director of the World Health Organization, Director General of the World Health Organization, and as Senior Fellow at the Center for American Progress. He's also an author of op-eds for the New York Times and of numerous books, including 2009's Healthcare Guaranteed, Reinventing American Healthcare from 2014, and 2017's Prescription for the Future. His latest book, Which Country Has the World's Best Healthcare, is the subject of tonight's talk. Please join me in welcoming Dr. Ezekiel Emanuel.
Thank you very much. It's really a pleasure to be here. Seattle's one of my favorite cities, and I'm sort of missing that I'm not doing this event live there. Let me begin by saying that I'm a super competitive person, and I love to rank things. And my kids, when they were growing up at dinner time, would always chide me for ranking schools, ranking my speeches, ranking people. Sometimes they would go to the news, find a person who was in the news, and ask me, how did they rank? So they would egg me on. Well, just to be true to form, I want to say that Seattle has the country's absolute best yogurt, Elenos. It's so good that the last 2 times I was there, I bought 6 quarts of it, packed it up in a duffel bag, and checked it in to ship it east to Philadelphia. The first time wasn't so good. About 3 of them broke, but I did get 3. The last time I did it, I got special styrofoam, special box, I shipped it, and I got all 6. So there you go. I'm a ranker, and I rank Seattle's yogurt as the best in the country. But for nearly a decade, I have resisted ranking healthcare systems. Lots of audiences like you would ask me, which country has the best healthcare? And I would say, well, you can't really look at that because we've got institutions, they're different, they came from a different place. And I also was pretty cognizant of the fact that there were 9 rankings already out there. The granddaddy of them all was the World Healthcare Organization ranking in 2000, and that ranked France #1 and Italy #2. But if you look at a lot of the rankings, That's the only one that ranks France, I think, in the top 10. Usually Norway and Switzerland come out high, but the Bloomberg ranking didn't have Norway, Switzerland, any other Scandinavian country, or Germany in the top 10. So I mostly concluded that these rankings were really not reliable. Then I actually found this fantastic quote from true British doctors about rankings. I just want to read it to you. They said, there's a significant relationship between a country's FIFA, that is, their soccer ranking, and its ranking by the WHO. Taken at face value, the statistical analysis suggests that if the national soccer team does well, the WHO score improves. There you go. If only that were true for the United States, maybe our healthcare system would get better. So about 4 years ago in 2017, I finally relented and began going around to 10 other countries besides the United States to understand their healthcare system and see what we could learn from them. I looked at Australia and Canada and France and Germany and the Netherlands and Norway, Switzerland, Taiwan, China, and of course, Britain. We tried to get a pretty good representative group. So a Scandinavian country, because progressives and of course people in Seattle think that everything from Scandinavia is good. I tried to get Switzerland because it's a darling of many conservatives. Britain and France, the UK and Canada, punching bags all the time. I thought we should understand them. In the Pacific area, I wanted to see what China was doing. Taiwan has very high satisfaction, usually when you look at the surveys. And then France, ranked number 1 by the WHO, ought to look at that. We rank them according to 22 different metrics, everything from do they have universal coverage, how comprehensive are the benefits, if you go to get service, you go to the doctor, you go to the hospital, do you have to pay, how much do you have to pay, how wide is your choice of physicians, are there waiting times that the public complains about, what are they doing about mental health in that country, how good is their long-term care, and then of course in the 21st century you can't but look at drug prices. Well, when all is said and done, came to 5 conclusions. Conclusion number 1, and this is probably no surprise to you, the United States does not rank in the top 10 countries. So not in the top. Conclusion number 2, on the other hand, it's not the worst. That I reserve for China. China, for assorted reasons, and we can get into this in the question and answer period, has a very poorly designed system with extremely low trust, and not infrequently doctors not only are bribed but get attacked, and actually some have been killed by irate patients. 3, well, it may surprise you that no country performs well on all 22 metrics, so that there's no A country. It was mentioned that I'm a professor, we always grade ABC, no A or A plus country. 4th, it may also surprise you that the United States actually excels at certain things. It's true, we're bad at many things, but there are a few things where we really are the world's leader. Let me just highlight 2 of them for you tonight. First, we're very original and creative and innovative in how we pay hospitals and doctors. Way back in the 1980s, we actually developed a new system for paying hospitals called DRGs, diagnostic related groups. Before that, insurance companies, governments used to pay hospitals by paying for everything that was done. The room overnight, the laboratory tests separately, the radiology tests or imaging separately. Now, it's not like that. You have 1 unit of payment, you go admitted for a heart attack, and you get 1 fee for that heart attack, and that has to cover the entire care in the hospital. The doctor's fee are separate, but the entire care related to the hospital, no matter how many laboratory tests or imaging is done, that diagnostic related group was actually pioneered in the United States in the 1980s, as I said. Subsequently, almost every country, developed country, uses that to figure out how they're going to pay doctors, how they're going to pay hospitals. Well, right now, we're innovating in payment a lot. We're trying to pay differently to get doctors to keep patients healthy and not just to treat their symptoms. And I have to say, when we were going around to a lot of other countries, they would always ask, well, what are you doing on bundle payments? Or what are you doing on this? Trying to understand these innovations in payment. Similarly, we have a lot of innovations related to how we deliver care, especially care for patients with chronic illness and mental health care. And we could talk about this in the question and answer, but these innovations in delivering care really, they haven't hit scale in the United States yet, but we have actually a lot of really top performers when it comes to chronic care and mental health care in the world, and that actually is something we can be proud of. Again, it has to become much more diffuse across the whole healthcare system, but we are innovating. The fifth and most important lesson in some ways is that we actually can learn a lot from other countries. We cannot go to other countries and sort of lift their system and shift it over to the US. That's just not a possibility. There's all sorts of reasons why that will not work. On the other hand, there are some very, very important particular lessons that we can get from other countries and actually bring them to our country. So I want to go through 4 or 5 of them in the time allotted to me, and then open it up to questions for you. One of the things that is very important that you learn by going to other countries is that there are a whole series of common problems that every healthcare system are confronting. All healthcare systems are worried about high costs of healthcare. Now, we in the United States, by far, spend the most of any country. We spend nearly 18% of our GDP on healthcare, but other countries which are spending 10, 11, 12% of their GDP on healthcare are also worried about high healthcare costs. Now, we should only wish we could get down to 12% of our GDP on healthcare. If we could, actually, we would save $1 trillion. And just imagine what we could spend that $1 trillion on that would be good for society. Think of all, the infrastructure we could improve, all the education we could get, free pre-K to kids, free college education. Think of free parental leave for newborns if in a family. We could have a better unemployment system for people. There's a lot we could buy. And one of the things that has heavily motivated me in my work on healthcare is to try to save more money so that we could free that money for other things. Closely related to high healthcare costs, every country is worried about high drug costs. Yes, they all spend much less than we do in the United States, but drug costs are rising in those countries too, and they feel very oppressed by the drug spend. Every country is facing the same problems on mental health. They see it's important, but they don't have a good infrastructure for delivering mental health care. They all see a big problem related to long-term care and what is called silver tsunami coming. Lots more old people, lots more people with Alzheimer's, and how to provide for them. All countries are trying to shift their system. They've been built focusing healthcare on hospitals, and almost every country, hospitals consume about 1/3 of the healthcare spending, and yet the problems of the 21st century are chronic care. In the United States, like many countries, 85 cents of every dollar is spent for patients with chronic illness, and it's not appropriate to be treating them in hospitals. They have a problem which requires attention every day and good self-management. Hospitals are about acute problems, not about managing chronic illnesses. So one of the things you learn is that every country is facing this same set of challenges. A second lesson is we often think of the United States as an outlier in terms of not having universal coverage, but we don't often realize that true universal coverage is a relatively recent phenomena even among almost all developed countries. Now, a lot of people think that, universal coverage started in Germany in the 1880s under Otto von Bismarck, but that's not true. He did start health insurance and state-sponsored health insurance, but it was restricted in the 1880s to urban industrial workers. He was trying to buy off workers who were agitating for socialism and even communism by giving them benefits like pensions and unemployment benefits and healthcare. True universal coverage began after World War II when Great Britain instituted the National Health Service, the NHS. So that's the first case where everyone in the population was actually covered. Germany finally got true universal coverage in 1972. Canada, different provinces got hospital coverage done, then physician coverage, but actually the whole country, you can date it from either 1972 or 1984 when the Canada Health Act was passed. Australia finally got universal coverage in 1983. They passed it in 1982. It was repealed by a conservative government, but then the conservative governments were rapidly voted out by the population, and universal coverage was reinstalled in 1983. Switzerland had 80% coverage by 1960, but only got universal coverage in 1984. Taiwan, it was 1985. France, it was finally in 2000. Well, the United States, we still don't have universal coverage. Around 91% of the population has health coverage. The unfortunate fact is we do not have a path in the United States to getting universal coverage. When we passed the Affordable Care Act, we thought, finally, we have a framework for getting universal coverage. But then the Supreme Court in 2012, in the NFIB case, ruled that states did not have to expand Medicaid. And today, we have 14 states that are implacably against expanding Medicaid. Texas, Florida, Georgia, and others. They represent a third of the population. And because they will not expand Medicaid no matter what, we have no path to universal coverage in this country. That's one reason about 2 weeks ago, my brother and I wrote an op-ed in the New York Times advocating for nationalizing Medicaid, taking it away from the states, putting it at the federal government. That's one way we could have a path towards universal coverage. A second lesson that I want to mention, or a third lesson that I want to mention, is that the countries I think we can emulate the best in America are the Netherlands and Germany, countries that actually rank pretty high on my evaluation. Why do I say that we can emulate them the best? Well, first of all, unlike many other countries, they have a unique system. Individuals and employers pay a payroll tax to the government. Then individuals choose their private health insurance. They call it sickness funds in Germany and the Netherlands. The government pays the premium to the sickness fund for the individuals and families. They pay based upon age, sex, and risk adjustment, basically how healthy or sick person is. Now, each individual has to pay a small premium as well, unless, of course, they're low income, in which case the government steps in. Individuals have free choice of which insurance company they want. The insurance companies then organize care, pay the hospitals, and pay the doctors. It turns out that kind of arrangement already exists in the United States. It's called the exchanges, where people pick their private insurance, the government subsidizes the premium, and you get a free choice of any of the insurance companies on the exchange. Similarly, in Medicare Advantage, that's the managed care part of Medicare, seniors get a choice of which private insurance company they want, and then the government pays most of the premium to that company. And often, the private insurance companies provide benefits that aren't routinely provided by Medicare, like dental care. So I think that the Dutch and the German systems are the most similar to aspects of the American system and the most easily implemented. Now, I know a lot of you are thinking, well, we prefer single payer, we don't like the private insurance. I understand that sentiment, but let me say, we Americans, we have a very confused, I would say even conflicted view of our relationship with private insurance companies. It's the easiest applause line for a politician to get, to bash insurance companies. The public already always will applaud that line. But when you poll the public and you say, well, we're going to institute a government program and we're going to take away your private insurance, popularity of that government program plummets when you say you're taking away private insurance. We hate insurance companies, but we like our own personal insurance company, and we're loath to give it up. Therefore, my view is this arrangement by which the Netherlands and Germany have the government collect money and then pay to the private insurance companies, and individuals can choose their private insurance company, has a lot of advantages. It solves a lot of problems. It simplifies the system. It means everyone's in the same pool. And it allows us to pick our insurance company, which we seem to like. There are a lot of other advantages to that arrangement, and we can discuss them if you want to ask. Let me say there is another advantage to the Dutch and German system, and that is they are the only two countries out of all the 11 that we looked at that had actually got a dedicated mechanism to pay for long-term care. Every other country we looked at, whether Norway or Britain or Canada, long-term care was funded by baling wire, chewing gum. It was always some kind of rigmarole arrangement, never solid. The two countries that had solid methods to finance long-term care were the Netherlands and Germany, and they built it right in to the payroll tax they charged. And that, I think, is going to put them in a much more solid place going forward when they confront the extreme cost of the aging of the population. So let me conclude by a final lesson, or two final lessons. One is that the United States uniquely puts the burden of having children get health insurance on families. In every other country we looked at, the insurance payments for children were covered by the government, not by the family. Health insurance costs in the United States for a family are really, really burdensome. Let me give you some numbers. I know it's getting late out there, and I don't want to overload you with too much numbers, but in private insurance, employer-sponsored insurance, the cost for individuals is round about $7,000, of which coming out of your paycheck is about $1,200 if you're an individual. So an individual pays about $1,200 out of the paycheck, and the total insurance cost is $7,000. For a family, the total insurance cost is $20,000, over $20,000, and the family has to pay about $6,000 out of a paycheck. 5 times that amount. That is a substantial increase in cost if you have kids to insure. Every other country says not doing it that way. So, for example, in Germany, the payroll tax for a German who's an individual, no family, is the exact same as the payroll tax for an individual who has a family with 2 children, even if they're earning the exact same amount of money. Children are viewed as a social resource, as an investment, and the cost of their health care is borne by the entire society, not just the family. You know, we wonder why we have such a low birth rate, why we have such a disincentive to having children. And one of the main reasons is it's really, really expensive. So that's $6,000 for family insurance coming out of an individual's paycheck. That's 10% of the median income in the United States just for health insurance. That is an enormous financial burden that we ought to relieve families of. Let me finally conclude with one of the topics I know that's on your mind, and that's drug costs. We ran around to all these countries, and the United States is the single country that does not regulate drug prices. All the countries give drug companies patents, but they regulate what they can charge. The United States is the single country that gives drug companies patents and marketing exclusivity through FDA approval, and then lets them set the price. Lots of economic theory, lots of economic practice says that's a formula for prices just going through the ceiling. Other countries regulate drug prices. Almost all of them adopt several common procedures. First, they use some objective measure of price. So some countries say, all right, we want to know how much health benefit comes from a drug. And the more health benefit, the longer the drug prolongs life, the higher the price can be. The less good it does, the lower the price is going to be. Other countries say, well, we're going to look at what prices are charged in a basket of countries, say 7 other countries, and we're going to set our price related to that. So Norway looks at, I think, 9 other countries and chooses the lowest 3 prices for every particular drug and sets their price as the average of those 3 lowest prices, which is one reason Norway has one of the lowest drug prices in the world. In addition, not in every country does the government actually negotiate the drug prices. There are non-governmental agencies, associations of insurance companies in Germany actually negotiate the drug prices with the drug companies. They almost all have very specified timelines for establishing drug prices. And if the negotiations over drug prices don't succeed, they often have binding arbitration, or the government can set the price. Finally, a number of countries have built-in mechanisms whereby the prices automatically decrease rather than increase year to year. So, for example, in some countries, a drug gets approved, it's unique, it gets a premium price, but then another drug in the same class gets approved, automatically the drug has to decrease. In Switzerland, they re-evaluate the price every 3 years, usually to decrease the price over time. If a drug's been on the one list in Australia, and then it goes to another list after 5 years, it automatically drops and can drop as much as 50% in the price. So there are lots of common mechanisms used by other countries to regulate drug prices. The consequence is no country spends as much as we do on drugs. We spend about $1,450 per person per year on drugs. We have about 4 to 4.5% of the world's population lives in the United States, and we spend almost over 40% of all drug spending in the world is in the United States. That doesn't have to be that way, and other countries have many, many good lessons that we could adopt to lower our drug prices. So thank you for listening, and I look forward to your questions over the next half hour or so.
Thank you for that, Zeke. I've got quite a few stacking up here. So 2 of them relate to the sort of relationship to employer insurance. Candace asks, how did healthcare in the United States get so tied up with employment? And then David follows on, does employer-sponsored insurance have a place in your ideal insurance system? And if so, what is it? And if not, how would you suggest we transition away from it?
Okay, one's a history question and one is a current question. So the history question really goes back to the 1930s when insurance started in the United States. And it started by during the Depression, and basically hospitals were empty because people didn't have money to pay for hospitalizations. And they came up with this scheme of, well, we'll give you a certain number of hospital days for a premium. And it began actually in Dallas, Texas, with the Baylor Hospital selling days in the hospital to the teachers union in Dallas, Texas. And that expanded and became known as Blue Cross. basically all the hospitals in a city and then all the hospitals in a state, saying, we'll provide hospitalization for you for a premium. And it was mainly sold to employers. Then in 1943, with the war on, wages going up and prices going up because so much of production was being diverted to the war effort, the government imposed wage and price controls. But the miners, the coal miners, said, listen, we're working harder and we're not earning any more money. And so the government made this little leeway that employers could offer fringe benefits up to 5% of the wages of workers, and they wouldn't be considered violating the wage and price controls. And that 5% turned out to be health insurance for a lot of people. After the war in 1954, we were in a struggle with Russia as part of the Cold War. We didn't want to socialize medicine. We didn't want to create single payer. And so the government or Congress passed a law that the amount that an employer gave towards health insurance was not deemed taxable. It's called the tax exclusion. So you didn't get taxed income tax or payroll tax on what the employer gave towards the premium. And that really spurred employer-sponsored insurance. So that's how it got tied into employers. And employers, up until very recently, were loath to give it up. They thought it was a fringe benefit that they used to attract and keep better workers. Most economists hate the idea because it gums up the labor market. People are stuck at employers rather than moving around or starting their own business with the responsibility for providing health insurance to themselves. And of course, as healthcare has gotten more expensive, employers are beginning to doubt that this was such a hotsy-totsy deal for them. So what should we do now? Well, I think, I've written that we should, I'm not a big fan of the tax exclusion because it's very regressive. It benefits rich people much more than poor people. Nonetheless, it's the single biggest tax benefit in our whole system. It's worth about $270 billion to workers. If we could get rid of it, I'm the first in there. I've written several ideas as to how to get rid of it. I don't think we're going to jump and totally get rid of it. But here's a secret. The economic pain caused by COVID has meant that 50 million Americans, workers and their dependents, have lost employer-sponsored insurance. And I think there's going to be a lot of pressure to move and have a very solid alternative to employer-sponsored insurance, maybe along the lines of the Dutch and German system. And so I can imagine a situation where we might have only two options in this country. Either you get your insurance through an employer, or you have this other German or Dutch type system where you choose a private insurer and the government pays them a premium. And that's it. Those are the two alternatives. And if you have this alternative, it's easy to see how you get to 100% coverage because no one's left out. The government, you get put into an insurance company and the government pays the premium if you haven't selected one. So I think that's probably the easiest path for us to get to universal coverage.
Tom, on that point, wants to know what percent of GDP do Germany and the Netherlands pay for healthcare relative to other countries with universal healthcare?
They pay around 12%.
You said that there were all kinds of lessons that we could learn from those two structures. I'm just sort of curious, is there, as you talked about sort of our pathway to adopting the sort of employer benefit model, are there any instructive lessons in the ways that those two countries adopted their current strategies that might, I mean, I know that trying to forecast politics is not exactly your game, but what about the origin stories of those two respective systems? Is there anything useful for us in those?
No. So Germany, as I said, Bismarck started the system, and he initially wanted the government to do it. He wanted a single payer, but it turned out that the liberals were opposed to that because they thought that that would give too much power to his conservative government. So they said that private sickness funds would be established at each employer. And originally there were thousands of these things, not hundreds of them. Now they're down to about 100 sickness funds in the country, and they're no longer you're no longer tied to an employer. But that's where employer-sponsored insurance started from. And in the Netherlands, they have a very a birth story they would prefer to forget, which is that when the Germans occupied them, they imposed the German system during World War II on the Netherlands, and they had to sort of pass some laws to try to rechristen the system subsequently. But that's really the origin story of the Dutch system.
Interesting. Dale wants to know which countries have the highest longevity, and is this tied to the healthcare rankings?
No, actually, it's not tied to the healthcare rankings, and there's a good reason for that. So the longest longevity of a large country in the world is Japan at 84 years. I don't actually think that's a very good measure of anything related to a healthcare system. So if you look at longevity, there are a lot of inputs into longevity, most of which are not anything related to healthcare. They're related to nutrition, exercise, not smoking, avoiding accidents, wearing your seatbelt. You do those 4 things, and you got a lot of points in the longevity category. No guarantees, of course. You can eat well, you can exercise well, you don't smoke, and you can still come down with cancer or something, God forbid, like that. But those are more important in terms of longevity. I actually am partisan to a measure that's called years of life lost, YLL. And that's to say, let's take a number, 75, 80. That's what we think people ought to get to. So how many people don't get to a full life at 75 or a full life at 80? You can pick a number. The average in the world is 72. That's too low for the United States. But we could get to, say, 75. How many years are lost where people die before 75? If they die at 68, they've lost 7 years to 75. That, I think, is much more, because once you get past 75 or you get past 80, I'm not sure it's all that desirable. If you look at Japan, there's a lot of people who are older, especially women, living alone, not a lot of social interaction. It's not a very happy-making situation. So I don't think we should try to just keep pushing longevity or life expectancy up and up and up. Of course, we should not have disparities in life expectancy by race or by class, but that's a different issue. That's not, we should push up life expectancy. That's the years of life lost is a problem. We want to get everyone up to 75 or everyone up to 80.
Babak wants to know if you could speak a little bit more about healthcare in Scandinavia, perhaps especially Finland.
Actually, we didn't look at Finland. We looked at my Scandinavian example. And by the way, Finland's not Scandinavian. It's Nordic, but not Scandinavian. And they make that subtle distinction. We looked at Norway as our example of a Nordic or Scandinavian country. And basically, they have a classic single payer system with the dominant mode being the government. People pay a tax to the government. That tax funds pensions and healthcare. The government then splits the money, pays some of it to 4 regional health authorities. Those 4 regional health authorities basically run the hospitals in different regions of the country. They also give money to municipalities to run a number of local services, including paying for primary care. So in Norway, primary care is funded by municipalities. You go to pick a local doctor, you go to local doctor. Specialists are all based at the hospital, and that money comes to the regional health authorities. One of the problems there is the incentive to be efficient, to move people out of the hospital to get care at home conflicts. Yes, that's in the interest of the regional health authorities, not so much in the interest of the municipalities, which then have to pick up the bill. And this creates a kind of tension. It is true also, doctors in Norway, they have a much lighter load than doctors in the United States. So on average, a primary care doctor in the United States will have about 2,000 patients that they care for over the course of the year. A primary care doctor in Norway, it'll be closer to 1,000 or 1,200. They often stop working at 4 o'clock in the afternoon, so they have a really good work-life balance. But things like chronic care coordination, they're just getting their heads wrapped around it. Mental health is still a problem. They have a very high substance abuse problem, and it's not managed particularly well. When it comes to long-term care, elderly people and their families have to pay a very large portion of income to get that long-term care. And there are also big complaints in Norway about waiting time.
All right. They're coming in lots of different vectors, and so it's going to be hard for me to group them. So forgive me if we kind of ricochet around a little bit.
That's all right. I'm prepared.
All right. Say you see two systems, employer and government, getting us to 100%. Does that, in your mind, mean expanding Medicare Advantage and canceling Medicaid in the exchange?
Whoever asked that question is a really smart person. The answer is something like that. I don't know whether you call it Medicare Advantage or whatever, but it's something like that. You give people a choice of these private plans or Medicare fee-for-service, and everyone's in the same pot. One of the problems we have in the United States is we have, this Medicare for seniors, we have Medicaid for the poor and the very poor elderly and the disabled, and then we have exchanges for people in between. That complexity makes it hard to figure out where you fit, A, and B, it also adds a lot to administrative costs. And so we could simplify the system, and we do need simplification. The United States has the most complicated system by far in the world. And I do think something like, as your questioner said, employer-sponsored insurance or Medicare Advantage, where everyone gets a pick of their private insurance and the government pays most of the premium and all of the premium for low-income people. I like that system. I think it has a lot of advantages. And I might say that, Medicare Advantage is the most popular part of Medicare now. People are very content with it, and disenrollment is pretty low. That
very smart person, by the way, was Kevin, just so you know.
All right, Kevin, very sophisticated question.
So, how would you describe lessons learned? I should say, Katie Goss's question also feels like it's an insider's question. How would you describe lessons learned from dialysis as an example to compare countries? As you know, ESRD dialysis is the only diagnosis that is covered by Medicare, no matter your age, but the U.S. doesn't cover comorbid conditions like other countries.
It's not the only one. Lou Gehrig's disease, ALS, is also covered, just for a very, very tiny, and it doesn't amount of people because not many people get it. But yeah, no, our system is totally screwed up, in part because we've got a duopoly. We've got two big dialysis companies. They have an interest in keeping people dialyzed in facilities, not necessarily catching them early and preventing them from getting dialysis. So that you manage their chronic renal failure so they don't progress to dialysis, not necessarily pushing them to transplant, and not necessarily using home dialysis. So yes, we need an improved system, and the way the government has paid for this has not incentivized moving off the current system. You could have you have to have a minimum of X percentage home dialysis and really you have to move patients to transplant. But we have not done this. And, dialysis is in facilities is super expensive. Now we're beginning to get our arms around that with the bundled payment that's been introduced. But even that is a little, I would say, not full and robust and very aggressive. We're moving in the right direction, but I think there's much, much more that could be done in that direction.
Deanna wants to know, what are some of the reasons that we have the highest costs for healthcare in the U.S.? Are the hospitals and doctors asking too much, or are insurance companies adding to the waste?
In some sense, I want to say all of it, but so a large part of it, not all of it, a large part of it is that we have very high prices. So we have high drug prices, and actually high drug prices account for the largest share of the difference between us and Europe. If we just brought drug prices down to more moderate levels, not even as low as the next highest country, we could save about 2% of GDP just in that one thing. Hospital prices, while hospital prices are regulated for Medicare and Medicaid, they're not regulated for private insurance. A lot of hospital systems has created local monopolies that increase their leverage and bargaining power with private insurance. So I have been an advocate, and I am an advocate for capping what hospitals can charge private insurance. And there's a very clever proposal out there, which I very much like, and it's actually been developed by a Republican. So this is nonpartisan, and that is you tie how much hospitals can charge to the concentration in the marketplace of the hospital system. So, for example, if it's very concentrated and really has a local monopoly, then you cap how much they can charge very low. If there's more free market competition, you allow them to go up to, say, 200% of Medicare. And that actually is its own internal control because hospitals will stop gobbling up other hospitals for bargaining power because they would be allowed to charge more if there were more competitors in the marketplace. So I like that proposal a lot. So those are two of the reasons. Prices we pay and salaries we pay to doctors and nurses are comparatively high. Switzerland is pretty comparable to us in terms of how high they pay the doctors. And I might note, Switzerland now has the second highest healthcare costs in the world. In addition, there's another reason. Almost every country I looked at, including, by the way, Germany and the Netherlands, actually have a budget for healthcare. They have a total amount they're going to spend. It's set by the legislature or the parliament. If they spend too much, doctors do too many services trying to increase their salary, actually there's an automatic ratcheting down of how much they get and the prices paid to them for the services. There are a few countries that don't have a budget like that, Switzerland and France, and they tend to be on the high end of spending, even among European countries. So I think having a budget is one way of actually keeping total healthcare spending down. And my own view is if we went to this sort of Medicare Advantage kind of program for everyone who doesn't have employer-sponsored insurance, you would want that to have a fixed budget. And that would actually, I'm a big proponent of we're spending so much in our healthcare system, we would want to keep it flat at under 18% of GDP as far as the eye could see into the future.
So I'm going to ask a naive question, my own personal follow-up then. Wouldn't that cap the total volume of medical services that could be provided? Is there any incentive for doctors to, if you've got an 8-patient, I'm going to make up a terrible number that I'm sure is wrong, an 8-patient day that is disincentivized to become a 10-patient day in that scenario? Is that correct? Does it have any impact on total services that are delivered?
There are ways of addressing that question, and I think it's actually a sophisticated question. What I think it actually ends up doing is encourages people to be more efficient. So if I'm a doctor and you say, I'm going to give you $5,600 per year to manage this kind of patient, right? Then I'm going to say, well, how do I actually lower the spend on that patient to increase the margin? And I'm going to try to think of ways of keeping them healthy, keeping them out of the hospital, making sure that they don't get sick such that they have to be admitted. And that's a different kind of thinking, which I think we need to instill more of on doctors. We grew up for 75, 80 years, probably till 2010. More is better. Getting more medicine, absolutely better. Well, those of us who are in medicine know, that's probably not true. There's a lot of harm that comes with unnecessary care, a lot of harm that comes with inefficiently delivered care. And we need to change the attitude of doctors. More isn't necessarily better. We need to keep people healthy. That needs to be your objective. And by the way, you don't just give out the money. You also monitor the quality of care that they're giving. You monitor how much they do the preventative tests, how often their diabetics get admitted to the hospital or are seen in the emergency room because they're not being well cared for. So I do think you have to combine payment with a monitoring of quality. Unfortunately, I think one of the things that has happened with the EHR and the whole trend in medicine with the Affordable Care Act is we've done a much better job about monitoring, setting standards for quality and monitoring quality.
Thank you for humoring that question. Toby had a question I should have bundled into the last one. That's kind of the last one I think about excess. It implies excess profits. He asked, what about excess profits in hospital, but then specifically medical supplies and devices as well? Do you have any thoughts about the sort of the others that accrete to the reef, the other industries like supplies and devices and improvements or efficiencies there?
It's all over the system, and we can pick out different parts, but I think the gist of the question is exactly right, which is supplies. There's a lot of extra costs in the supplies and the way the supply market is run. The same thing is true for devices. So the best way, in my opinion, is to actually push on and require hospitals to be more efficient, and that's going to require changing how we pay them and how much they can earn. If they can make more money, right, by increasing revenue, they'll do that rather than do the hard work of trying to become much more efficient. Go into any hospital, go to a surgeon and ask a surgeon, could you reduce the spending during your operations? And they say, of course. We open a lot of trays. We just open them, even if we're not going to end up using them, or there's a low chance of using them. Starting on time. The most expensive part of a hospital is an operating room. How do you know that? They charge by the minute, right? They're not even like lawyers charging by the 10-minute unit, right? They charge by the minute. Well, if we don't start surgeries, if we have a surgery scheduled for 7:30 and we start it for 7:40, that 10 minutes is a waste. And it's typically a waste of 5 or 6 people's time. So doing things like that can dramatically enhance efficiency. We have operating rooms and they operate 5 days a week, not 6 or 7 days a week. Why is that? Lots of countries have MRI scanners that go, if not 24 hours a day, 20 hours a day. So you can have a schedule. I've got a scheduled MRI for 2 a.m. Well, that's an efficient use of capital. And, is that a problem? Well, if the cost of the MRI were not $3,000, but $300, wouldn't that be worth it? So there's a lot of things we can do to greatly enhance the efficiency of our system. And by the way, if we simplified it to one Medicare Advantage system, we'd also lower the administrative costs substantially. And that's another big advantage that I don't think the complexity of our system adds a lot to the administrative costs.
Forgive me, because I look down and look back down, and suddenly there are actually a few more questions around cost. And you've glanced but not quite nailed it. So Chloe asks if you've covered medical professional compensation variances per system. Yes, you have, but do better healthcare systems have lower overall compensation? And do you think that's a large barrier to changing our system in the U.S.?
No consistent relationship as I could find. Some systems, doctors are well compensated and they get high marks. Some system doctors are not that well compensated and they're not in our top tier. So it really is all over. And you also have to remember, compensation can't be disentangled for the other things society does. So look at Norway. The doctors don't make that much money, actually, but they have very high respect. And they've got lots of government provided social benefits, free education for their kids. In Norway, almost no parent pays anything for their kid after they're 18 and graduate for high school. It's just, not part of it because there's college is free, jobs, they've got compensation to go to college. Many of the other things, retirement is well done through the government. So you've got you have to look at it within the whole package and advantages of the society, and you can't just pull out salary as one element. So I think that is something that we need to be aware of when we say, oh, they've got much lower salaries. It is true they have lower salaries in other places, but no place in the world do most doctors come out with $190,000 in medical school debt that they have to pay off? And again, we have a crazy system. I think that's an idiotic part of our system. We could tax all hospitals 1% and have free medical school, and if doctors go into, say, oversubscribed lucrative practice, radiology, ophthalmology, or orthopedics, you have to pay that loan back. You go into primary care or you go into pediatric specialties where we don't have enough doctors, we're going to forgive that loan. I mean, that's a much more sane system, but we haven't done that. And so, one of the compensations is we pay doctors a lot.
John wants to know if lobbying and campaign contributions play a role in driving up U.S. costs.
I'm sure they do, and the drug companies can tell you, they wouldn't give up their lobbying money for anything.
Yeah. Okay, so let's see here. Oh, you just addressed subsidized medical education? Yes, out in front of it. See? Okay, so now we're finally in sort of grab bag zone, but we do build to a big climax. In leaving insurance companies engaged, he says in charge, but engaged in some way, how do we address issues where people are denied coverage, rates suddenly going sky high, any of the other problems that sort of beset individuals dealing with private insurance? You have thoughts about that?
100%. Look, if you have Medicare for all, Medicare Advantage for all, just as an example, there is no denial of care. You've got to cover whoever selects your plan. That's part of the deal here. And you've got to cover them for the same premium that the government's going to give you. Yes, it'll be adjusted for age, sex, and health risk of the people, but that is it. And you might want to adjust it also for some historic disparities that have existed. So some countries, not actually ones I looked at, Israel is a country where they actually pay more for lower income individuals because they think that they haven't gotten enough attention from the healthcare system. So I'm not worried about excluding people for pre-existing conditions or raising the rates for people who have health problems or denying them coverage. Now, this issue of utilization management and things like that, that comes about because we're spending too much and insurance companies use it to police what doctors order. And we know that doctors are not uniformly efficient, often do unnecessary services. So it's a vicious circle. One of the reasons I advocate paying doctors differently is you can get out of that circle. If you pay doctors a capitated amount, a fixed amount to care for a patient, this utilization management is being done by the doctor. It's not being done by the insurer. And the doctor is aware of how much they're actually spending and caring for different patients and trying to organize the care in a more efficient way. So I think part of all that denial stuff is really a result of the fact that MRIs are so expensive and doctors are not thinking about how much they're ordering and trying to keep people healthy and just attending to them once they've gotten sick. We can get out of that vicious circle, and the best way to get out of it is by empowering doctors through different kind of payment mechanisms.
Do you have thoughts about the United States loss of public hospitals and the privatization of hospitals generally, especially as that's come into view during the pandemic with private hospitals closing and even laying off healthcare workers right now?
Well, those are two separate issues, okay? So in the 1990s, there was as for-profit hospitals were coming in, there were a lot of concerns about compromising quality and not being as good as the private hospitals, et cetera, et cetera. And a lot of studies were being done, most of the best of them being done by Steve Shortell out of Berkeley. And I think the upshot of that is not really different. Maybe private hospitals were a little more efficient than public hospitals because of the profit motive. But you couldn't really find a difference in quality and any of the other metrics that people worried about. Of course, there is a difference in where they locate the hospitals because they want to have more patients with private insurance that pay more. But that, again, is a problem we can solve in a different mechanism by, say, paying Medicare Advantage. You get to use the Medicare rates and everyone's being paid the same way. We're not going to have this differential that I mentioned before. And that, I think, we have to think creatively about how to solve the problems that we're really worried about, and not look at pseudo indicators. For-profit status, that must be bad. Look, I'm not a big advocate for for-profit in the healthcare industry. It's there, and we're not going to get rid of it because this is the United States. But if there's no difference, then I worry less about it, and I try to worry about the problems that are really big, the problems of cost, the problems of quality of care, the problem of patient experience in the healthcare system. I think those are really the places we need to look for improvements.
We've got just a few questions left, so I want to actively dissuade anyone else from adding any, because they're all great, and I want to get to all of them. But Kenton wants to know if you have thoughts about recognizing naturopathic services, chiropractors, or other non-traditional services.
Well, there are some places that do it. Switzerland has done it and gone back and forth. Germany has done some of those services and gone back and forth. In general, they're not recognized. And in general, in my humble opinion, we should cover dental care and vision care before we do naturopathic care. We don't do that for adults. And I do think that would be the place to start rather than covering naturopathic care. Chiropractors can be a little different, given in the context of physical therapy, especially for things like back pain, may be a good substitute, given evidence that we have for actual surgery.
I told you we're going to hopscotch around. If the United States quit paying much of the world's drug costs, Greg wants to know, would the loss of income to drug companies decrease development of new medications?
Really long discussion, and I can't answer it here. It's just not. I mean, that's a whole hour lecture separately. There's a lot of debate about how much they spend for R&D. Suffice it to say, they're doing really well. The profit margin of the top 10 drug companies in the United States are about 25%. It's the most profitable single industry. They're really doing quite well. And all this claim of we got to charge a lot of money for research to get back our money in research and development doesn't really hold up water. And again, we can go through the data. Do you know the company that spends the most money on research and development?
What is it?
Amazon. And they're notorious for what? Low prices, low profits. So you got to put it in context. So I think if you actually link the price of a drug to the health benefit, you actually would incentivize better getting more health benefit, rather than now you incentivize, okay, how much can I sell that drug for? That's what they are investigating. So one of the consequences is simple. Last I looked, which was a few months ago, there were over 640 cancer drugs in human trials, right? Yeah, cancer's really important. Why do they have so many drugs in cancer trials? Because the minimum drug price is $10,000 a month, $120,000 a year. On the other hand, there are less than 40 antibiotics in human trials, and yet we have serious threats from antibiotic-resistant bacteria, but you can't get research done on antibiotics. Why? Because even if they're really beneficial, the prices cannot be that high. And, it's not a law of nature, it's just a law of what the market will bear. That makes no sense. So if we actually link the price to the health benefit that we got, you might actually incentivize better research. Maybe not more, but it would be more health impactful research. And that does seem to me worth it.
Antoine has been very patient, waiting for me to ask if you have thoughts about health literacy in other countries and in your higher ranking countries as opposed to the United States. How informed are consumers of healthcare in higher ranking systems than in America?
Well, I wish I'd asked that question. We did not actually go into that. So I apologize. I have no educated answer to that question.
And not even a hunch you're willing to venture, it sounds like, because that wouldn't be right.
No, sometimes we think Americans are, we don't understand. But you go to a lot of other countries and you like often scratch your head about what they do and some of their beliefs. So I'm not willing to venture without more data.
I'm sort of curious, even though we have no time for me to freestyle, are other countries subjected to the kinds of consumer-directed advertising for pharmaceuticals to encourage, people to ask your doctor about fill in the blank, with a daisy and a smiling child?
Only one other country has permitted direct-to-consumer advertising for pharmaceuticals, and that is New Zealand. Every other country prohibits it. It's
kind of high functioning, so that's not so bad then.
It's kind of crazy. Yes, most other countries don't permit it.
So
no, not most. All other countries don't permit
all other
it.
Except for Jacinda Ardern's
It's a doctor's decision. It's not something that the public is educated enough to be targeted for advertisement.
Well, it seems like it's caught in this liminal place where we're being encouraged to advocate for ourselves and to have more knowledge, to have access to our records and more knowledge of our charts, and the all the language of doctors putting us into collaboration with them. And yet I'm quite happy to entrust my doctors to choose what medications I should be on. I've always felt comfortable with that burden being shifted to me, but maybe
I think you are right, which is, look, if you get a chronic illness like diabetes or congestive heart failure, you do have to understand the illness. You have to understand the medications you're taking, because you have to self-manage your condition every day. You need to understand if you have congestive heart failure. If your weight goes up, you need to call the doctor and you need to adjust the amount of your diuretic to reduce the fluid. Otherwise, you could get into a problem of too much fluid in your lung and end up in the hospital. Similarly, with diabetics, you need to, really monitor your glucose and be aware of what influences that glucose. So there is a very important role for self-management, especially around chronic illnesses. But that's different than saying, oh, that drug, I want that drug. That's a totally different cockamamie way of getting someone onto the right set of medications.
It is. I shouldn't have brought it up. Katie had a great question before. It's as good. She wants your elevator summary of what we should do as a society, that's American society, to manage COVID-19. You didn't think you were going to get away without talking about that, did you?
Look, our biggest problem is we have had a poor leadership at the top when it comes to COVID-19. Delayed introduction. When we introduced the public health measures, physical distancing, avoiding crowds, closing non-essential businesses, wearing face masks, hand hygiene, and the whole suite of them, the problem is they were not rolled out nationwide, enforced, and done it stringently. And you had it in some places, but not in others. And so we never got a control over the illness. And you can see that, New York had a high rate, 3 months ago, now a very low rate. It's moved to the south, and it was totally predictable. I was called earlier today by the Canadian broadcast company. They interviewed me 2 months ago, and they said, well, where's it going? And I said, look, if you just look at places that are opening up, that have not imposed these stringent measures, in 4 to 6 weeks, they're going to have a big explosion in the number of cases. And he was calling back to just confirm, you're a prophet. You saw this. I said, no, I didn't see this. It's just basic epidemiology. You don't got to be a genius or a brain surgeon to know that this is going to happen. And we didn't do that. And 2 days or 3 days ago, the Washington Post published this really worrisome graph. You look at Europe, and it goes up and comes down because they stringently impose, places like Italy, lockdowns, and then slowly opened up with the least risky places and then moving progressively to more risky places. We went up, we came down a little bit and have plateaued. And in most parts of the country, it's actually going up because we didn't do this stringently. We have to do it stringently, and we have to open up, not willy-nilly. Oh, indoor restaurant dining, bars, tattoo parlors, salons. Those are places where, the way the virus is transmitted, those increase transmission. There are 4 things that increase transmission, right? enclosed spaces, being indoors with crowds for a prolonged period of time, and forced exhalation, sneezing, coughing, yelling, singing, right? That's one reason that, a third of all cases are family-to-family transmission, because you're enclosed with the family for a prolonged period of time when some people are sneezing, coughing, yelling, whatever. You don't open up a bar. It's got all of those problems, right? It's the last place that ought to be opened up. Similarly, we're rushing to open gyms, but gyms create the same kind of problem. You cannot do it that way. Even the president's pretty anemic plan for reopening the economy had phased reopenings and not rushing to the last most high-risk situation first. That's what Texas did. That's what Florida did. And you're seeing the consequences. This is no genius, prediction. We want to get a whole handle on this thing. We have to be serious about imposing those public health measures and making sure we get very low down in terms of new cases before we open up, and then open up in phases. We do that, we might have a chance of seeing little embers of outbreaks and then doing contact tracing and quickly imposing isolation so that they don't lead to major outbreaks. But we haven't had the discipline to do that.
We are near the end. Yen posed a great question, but it's very similar to one that was the very first question posed, and I want to make sure we hit it, which is from Dr. Brock Gaster, who proposes this hypothetical. You're magically made the U.S. healthcare czar. So that means you can choose 3 quickest changes to our healthcare system, which would immediately come into effect. Zeke, what 3 changes would you make?
Well, I've told you 2 of them already, right?
Well, recap them, sum them up for us.
Switch the system so you have either employer-sponsored coverage or this exchange, Medicare Advantage, or a big exchange where everyone else is in it, and we pay for it through a payroll tax. That's one. That gets us to universal coverage with a uniform benefit package. I think we need to regulate drug prices. That is number 2. We need to bring them down. And I would say number 3, we need to change how we pay doctors and hospitals, alternative payment away from fee-for-service, so that they have an incentive not to just do more and more and more, but they have an incentive to actually consider both the quality of care and ensure that they're doing things in a cost-effective, efficient manner.
So that's the United States. Your final question, should you choose to accept it, Zeke, is Elenos is to yogurt as blank is to healthcare.
I love it. So you want the answer without reading the book.
Wow!
Really? Just like my Wharton students. So, unless you work hard at it, you don't really retain the information. If I just give it to you, you'll forget it tomorrow. So we really did come out with not a single country that was the best. We came out with sort of a group in the top tier, Norway, Netherlands, Germany, and Taiwan. But I put an asterisk near Taiwan because it has super high satisfaction, super low cost, but doctors there are way overworked. They see 60 to 100 patients a day, so you're not going to get a lot of FaceTime with your doctor there. And hospitals have been described as undergraduate dorm rooms, where they're very Spartan. Family is expected to do a lot of the care, taking the patient to the bathroom, feeding them, etc. Very different from what we're expecting. Nonetheless, there is high satisfaction there. And it is pretty low cost. But if you want no cost at the point of care, you're going to think about England, you're going to think about Canada, you'll think about Australia and the public hospital system. So it depends really what you care about. You want no waiting to see doctors, you want to be able to see any doctor in the country, you're going to think about Germany, Switzerland, and France. So it really does depend upon what combination and what your priorities are.
So I heard sometimes you want Elenos, sometimes you want Yoplait, but you never want Dannon. Is that the idea?
Very good.
Zeke, I want to thank you for being with us tonight. It's we're 21 years Town Hall, but you've never been with us for any of your previous books, which I find criminal. So we've sort of rectified it tonight. You have yet to actually be present in our great hall, but we'll try to get that done the next time you've got something to share with us in Seattle. Thank you so much. I just want to.
This has been terrific, and I want to thank your audience for great questions, and obviously a very, very, very knowledgeable audience that was jumping to conclusions and making connections that I don't think I've seen in any other audience.
Well, I'm going to brag for a second. We are often told that we have some of the smartest questions when an author is on tour, and you all proved it tonight. So thank you all. And you didn't hear the whole story, please pick up your copy of the book through Third Place tonight. And be sure to check out our calendar because we got another week plus of terrific stuff before we take a few weeks off in July. So thank you all for watching, and thank you, Zeke, for being with us, and we'll see you all soon. Bye-bye.
Take care. Bye.